Hey guys, Dr. Sood here with Mind Media Psych. Today is our first episode and live discussing psychiatric medications. We're going to do lives from 6 to 6:30 p.m. Eastern Standard Time, Mondays through Fridays, to just educate the masses about, psychiatric treatment, psychiatric medications, all things like that. Super stoked to see you, Michelle, and super stoked to see you, Don Pickup 155. Glad you're here. Basically, the series that we're going to provide is all different type topics and comment on videos to help us see what topics are going to be discussed. Today, I'm going to talk about sleep. And sleep is super important, especially in the mental health world, because a lot of us are not getting a lot of it. So, why, as psychiatrists or as physicians, do we talk about sleep? Well, it's super important because we spend a good portion of our days sleeping in our 24-hour period. And a lot of psychiatric illnesses can be derived from poor sleep. For example, people who have poor inattention might have ADHD, or they can be sleep deprived, which can lead to significant issues in attention or focus. We call waking up on the wrong side of the bed, right? Well, sleep deprivation, difficulty getting to sleep, difficulty staying to sleep can lead to changes in our mood. Often we see issues with severe anxiety, and that can wake up individuals and have difficulty with sleep. So I think it's really important to discuss sleep and be aware of sleep when we as physicians talk about medications and things like that. But maybe I could use this time to kind of go over what sleep architecture is. So sleep architecture is basically the kind of phases of sleep we go into. There are different phases of sleep. Typically, there are 4 stages or phases that the human body goes through, and those are stage 1, stage 2, stage 3, and REM sleep. REM sleep is all of these stages have different forms and functions of sleep. And as we grow up from being a child to an adolescent to a young adult to an older adult, our stages of sleep shift throughout. And I'm going to answer questions as I talk about where did you get my MD from? I got my MD from Virginia Commonwealth University in Virginia, and I did my residency training at NYU and my fellowship training at Cornell and Columbia. So when we talk about the stages of sleep, right, there's stages 1, 2, 3, and REM sleep. And what are the phases or what are the functions of these stages? Stage 1 is typically what we call light sleep. You kind of go back you start falling asleep, start falling you're kind of like in this twilight phase. Stage 2 is where we see a lot of kind of start transitioning into deeper sleep. On an EEG, we can see what we call sleep spindles forming during this time. Stage 3 is deep sleep. This is delta wave sleep, where individuals spend a good majority of the night in. And then the fourth stage, or what we call REM sleep, is where we dream. It also stands for rapid eye movement. And so during these times, our eyes will kind of be moving back and forth. We'll be having dreaming, but our muscle tone is actually pretty low. And so we can't really enact dreams. That's why if we could, the world would be a bit of a disaster. There are issues and sometimes sleep disorders in which people have muscle tone during their REM sleep, and that can be very dangerous, right? You have a nightmare and you think you're, driving in a car and you wake up and you're in a car. That can happen. It's very rare though. So these are the stages of sleep. So in psychiatry, we kind of think, what is the best treatment for sleep? It can be a whole slew of different things. And basically our job in psychiatry is to get in medicine in general, is to understand what your sleep habits are, what your sleep hygiene is, right? And so we typically do a sleep log to get an idea of when you lay in bed, when you go to sleep, how long you stay asleep in bed for, and do you have multiple times that you wake up throughout the night? And if you do wake up multiple times throughout the night, how long do you stay awake for? And what time do you wake up? Do you take any caffeine when you wake up in the morning? Are there any medications you take in the morning or the evening? Do you consume any alcohol or any type of other substance that could alter your sleep, right? All of these questions are super important before we provide any type of medication, because sleep is a natural phenomenon. We all sleep and we all sleep different hours. There's a genetic predisposition for how many hours we may or may not sleep. And so it's really, really important that you kind of really think about, all of these components before you start a medication for sleep, right? So sleep hygiene is often the biggest thing I always talk about with patients, because sleep hygiene shows that, if you have a screen in your room, if you have your cell phone in bed, if you associate your bed with more than just sex and sleep and other things like reading or work or leisure and hanging out, your sleep is going to become disrupted. Additionally, we also want to highlight, substances can affect our sleep. Caffeine has a half-life of 8 hours. So I typically recommend to individuals that it's really, really important that if you drink coffee or you drink tea, that it's no longer past, 2 p.m. often or 1 p.m. often, because it can keep you awake, and that can be an issue for some. Additionally, alcohol disrupts the sleep architecture. How? It makes us really tired when we drink. Well, when we think about sleep, right, and we think about kind of slowing down the brain and letting it rest and relax, we activate a receptor called the GABA receptor, right? Alcohol binds to a portion of the GABA receptor. And the GABA receptor, and this is a little bit neuroscience-y, but just mind you for a second, when we bind to the chloride channel, which is what the GABA receptor is basically part of, you increase chloride ions to go in through a neuron, which basically slows it down, right? It decreases it. Alcohol does that, right? Medications can do that as well, but alcohol often does that a lot. Your body is homeostatic, so when it notices that it's being suppressed constantly, all the time, then what ends up happening is that it upregulates excitatory receptors. And these excitatory receptors are called glutamate receptors. And so when you upregulate all of that and the alcohol becomes metabolized in your bloodstream, say you have a glass of scotch, at like 9 or 10, you feel sleepy, you feel drowsy, you fall asleep. At 3 or 4 in the morning, the alcohol is metabolized, but you've upregulated all your excitatory neurotransmitters and receptors. So what ends up happening is you jolt right awake and you wake up. And when you wake up, you're kind of like alert and anxious and have a dry mouth. And that's how alcohol can disrupt the sleep architecture. So I share all of this, right? And I talk like, let's talk sleep meds, but I share all of that because modifying each of those variables are very important before starting a medication. In medicine, in psychiatry, medicine gets a bad rap for starting medications quick, but a lot of the situation is doing a really detailed sleep history and modifying these factors before you add a medication can alleviate these things. But that takes a lot of work. And so there are different medications though, right? There are sedative hypnotics and hypnotic medications that are called Z drugs. There's also benzodiazepines, and there are also non-hypnotics. So let's split this into 3 categories because I see that there's a lot of questions about sleep meds in general, right? So let's talk about, I've seen a ton of questions about trazodone. Let's talk about trazodone. Trazodone is a medication that is often used for chronic insomnia. At low doses can be used as something to fall asleep for, but at higher doses, like 150 and 200 and 250 milligrams, used to be used as an old antidepressant to help people not feel as to not feel as sad or melancholic, right? But we don't really use it anymore because there are better medications for depression. At low doses, trazodone has been used. It is FDA approved for insomnia. I don't know if it is actually FDA approved for insomnia, but it is the second most prescribed medication for sleep. And so at 25 to 50 milligrams is often prescribed, and it has what we have an antihistaminergic tone to help people fall asleep. It has histamine is a neurotransmitter or a peptide in the brain, and histamine keeps people awake. So things like Benadryl and things like Unisom or Desoxyn or trazodone have antihistaminergic tone. They block the histamine receptor, causing people to fall asleep. And so trazodone is often given. There's weak evidence per the American Academy of Sleep Medicine for trazodone, but it's often given for sleep. There are side effects to trazodone that people should be aware of. This can be dry mouth, constipation, urinary retention. These are what we call anticholinergic effects. There's also a side effect that somebody said trazodone. Yes, it can cause, very rarely, but it can cause penile erection that is not intended and can be very painful in men, priapism. And so it's really important to kind of be aware of that. The other medication I'm seeing in here is Benadryl. Benadryl is a medication that is also known as diphenhydramine. It's an allergy medication, and it often can be used for sleep. Again, antihistaminergic tone. The issue I have with Benadryl and other anticholinergic medications is that in older individuals, 65 and older that I'm thinking, or 70 and older I'm thinking, they often can have, these things can lead to cognitive worsening or cognitive decline over long periods of time. And so I'm often kind of a little weary about prescribing that medication in older individuals. However, it is often given in kids, it is often given in adults for sleep. Atarax or hydroxyzine, which is also a very common medication, is also antihistaminergic, and that talks about helping people fall asleep. These, again, are non-benzodiazepine medications. And so trazodone, again, a lot of people like it. They find it easy to fall asleep. But again, a lot of these medications are not really have strong evidence from the American Academy of Sleep or for sleep medicine. Just because they're FDA approved doesn't mean that other bodies of literature or other bodies of evidence really find a lot of strong evidence for it. So they can also cause weight gain. You're absolutely right too. Some of these medications can cause weight gain. Depends on the dose. One of those medications is called mirtazapine. Mirtazapine is often given for sleep at low doses, 7.5 to 15 milligrams. It can be often given for sleep. It's sometimes given to older individuals because it helps with increasing their appetite as well. But it can, if individuals don't want to gain weight, it can have that side effect. At higher doses, we often don't see actually much improvement with sleep. It's more used as an antidepressant. So there's also a question of Belsomra. Belsomra, I believe, is an orexin antagonist. It's a medication, I think, that is, if I'm not, it's brand new. It's often given for issues with difficulty, obviously, for help for sleep. It's expensive. Orexin is a receptor that is found in your spinal cord as well as in your brain. And it is a medication that, or it's a receptor that if you block, you can help fall asleep. In narcolepsy, we have orexin agonists, which can wake people up. And that's what he said. What meds are used for hypersomnia? One of those would be orexin agonists. So Seroquel is also another medication. I'm seeing that in a lot of comments. Seroquel is an antipsychotic. At low doses, again, a lot of histaminergic tone. That's how a lot of these medications work. Histaminergic tone is the kind of version how Seroquel works. It's given at very low doses for sleep again. This would be like 12.5, 25 milligrams, 50 milligrams, things like that. And so Seroquel can often be given for medication. I don't typically like it because it has long-lasting effects in terms of weight gain and lipids. Your lipid profile can increase. There was data to show that the weight gain over a year in about 600 people at low doses of Seroquel was roughly 2.5 to 3 pounds in a year. So it's not necessarily the worst. But when I see people saying I take 300 milligrams. When you're getting at higher doses, you're typically treating a mood disorder or you're using it for antipsychotic properties. So these are the general, there's other non-hypnotics that are given. And so these are the typical ones: trazodone, Atarax, Benadryl. These aren't habit-forming whatsoever. They have side effects, so always talk to your doctor about these different medications. And right, I said in the beginning, if you're just joining me, Dr. Sood here, the biggest thing is to talk about focus on sleep hygiene. and learning the risk factors and learning how your sleep works, the best thing you can try is map your sleep. So UCLA sleep log, if you Google that, will be really helpful for you to get an understanding. The second thing is talking to your doctor that if those factors don't improve and you need a medication, the non-hypnotics are typically the first line. They're not habit forming. A lot of people have talked about melatonin. Melatonin is a natural endogenous molecule that we create from a gland in our brain called a pineal gland. It helps sleep regulation, not the kind of, and the molecule itself can assist with helping the onset of falling asleep. Often it takes a couple hours to kick in, and it's usually somewhere between in the pharmacy you can find like 0.5 milligrams to 10 milligrams is where people often are taking the medication. It does not help with maintaining sleep throughout the night, but it helps with people falling asleep. And so melatonin is a cheaper alternative that often people try. There can be a little bit after, like waking up in the later on in the day, in the following morning, there can be some grogginess. The other aspect of this, and I need to research this more, but I read in some literature that it can sometimes delay puberty in children. But I think there's like high doses and being chronically on melatonin for it. So those are melatonin, and then there's Ramelteon, which is a melatonin agonist. These are expensive medications that basically are not generic, and they help onset of sleep, but they're not significant. I would always consider using melatonin or the other medications. Again, a lot of people are asking about trazodone. We already talked about trazodone. But again, somebody also commented cognitive behavioral therapy for sleep. Absolutely. That is the gold standard for insomnia. I kind of mentioned it in sleep hygiene portion of this, but cognitive behavioral therapy for insomnia is the treatment of choice if you can modify the factors. Dr. Kristen Casey, I think she's one of my friends she's definitely one of my friends on here. Follow her. She's a cognitive behavioral therapist for insomnia. I think operates out of Kansas City. I might be getting all that wrong, but she's like 150,000 followers. She's one of her friends. If you're interested in cognitive behavioral therapy for insomnia, check her out. And she's accredited. She knows what she's talking about. I don't want you guys to go to charlatans who are talking about this who aren't well versed in it. So we've talked a lot about sleep hygiene. We've talked about cognitive behavioral therapy for insomnia. We've talked about non-hypnotic medications such as trazodone and Benadryl and Atarax and all of that, and melatonin. Somebody keeps on talking about clonazepam. Let's talk about benzodiazepines. So there are benzodiazepines that are FDA approved for sleep. However, you always want to be a little bit careful because benzodiazepines in some way, shape, or form are habit forming. It's very hard to kind of come off of them. They can really help, especially if somebody has severe nightmares and panic attacks and you need something to help fall asleep. Issue is that you can't combine alcohol and benzodiazepines. That can be very dangerous. The other aspect is that there can be a suppression of REM sleep with benzodiazepines. And so remember, we want to maintain our sleep architecture, stages 1, 2, 3, and REM sleep. So if you're on benzodiazepines, that's totally fine. Have an active conversation with your doctor about how that looks like in the long term. There are long-term side effects of benzodiazepines, not just about the grogginess and the sedation, but the other aspect is that, there's data to show that being chronically on benzodiazepines for multiple years can lead to dementia. So I'm always very, very, very careful about, prescribing benzodiazepines for sleep. I do not like to prescribe benzodiazepines for sleep. Are you an MD or psych doctor? I am an MD. So that's what I'm talking about, meds. So basically and memory loss, somebody put that as well. So I think it's always important. And so basically, let's talk about the non-benzodiazepine hypnotics. These are called the Z drugs. These include things like Zolpidem or Ambien, eskepolizone, also known as Lunesta, and then Sonata, which is known as Zaleplon. these medications are non-benzodiazepine hypnotics. They bind to a portion of the GABA receptor, which causes the hyperpolarization of the neuron, which basically decreases firing. You fall asleep. These medications are often prescribed all the time. Ambien is the number one prescribed medication of all these medications. What are the side effects of them? Well, what's the function? They help you fall asleep. They help you maintain sleep, right? And help you stay asleep throughout the night, particularly Lunesta and Ambien. And they come in different formulations, oral medications, things like that. But the issue is that they have side effects, of course. One of these are confusion. They can have visual hallucinations. You can have excessive daytime grogginess. But the biggest side effect and the most concerning side effect with these medications is basically acting out kind of like your dreams in a certain way. So what does that mean? Well, basically a lot of individuals, 5 to 18% in a recent meta-analysis, looked at individuals who had this side effect where they would basically not remember what they did in the morning, and that can be a little bit dangerous. You have this is the other side effect. Anterior grade amnesia. You can't have difficulty forming new memories, so that's one side effect. The other side effect is acting out some of the dreams. So we kind of talked about this before. And that can be like, somebody might joke and say, I'm just heating up my bowl of spaghetti at 2 a.m. and I can't remember it. Well, you could hit your head, you could fall, right? You could operate a motor vehicle. People have operated motor vehicles without remembering or waking up and being in a motor vehicle and driving. So it's always a little bit dangerous with these medications. You also want to make sure that if somebody has a substance use history, to be very careful about prescribing these medications. Okay, so let's talk in summary. What did we talk about tonight? We talked about sleep hygiene, looking at the factors of sleep hygiene. We talked about cognitive behavioral therapy for insomnia as the number one goal treatment for insomnia. After trying all of that and those don't work, we talked about non-hypnotic, non-benzodiazepine medications, which include trazodone, Seroquel, Atarax, or hydroxyzine, Benadryl, all of which can be a sleep aid, but nothing that you want to take chronically. Melatonin, Ramelteon, these things like that. And then we talked about benzodiazepines and then non-benzodiazepine hypnotics. So these are just generally the guidelines for sleep. A lot of people have talked about a sleep study. And somebody said didn't talk about narcolepsy. Happy to talk about narcolepsy. Narcolepsy is kind of the opposite of insomnia. It's hypersomnia, categorized also with cataplexy, where your body loses muscle tone and basically falls to itself. You don't have to have cataplexy as a diagnostic criteria, but often these individuals are falling asleep multiple times during the day. They can fall asleep, and basically when an emotional stimuli occurs, something makes them laugh, something makes them cry. It can be really frustrating for the individual because they might be taking a test or they might be driving, how dangerous that could be. Typically, the best way to treat narcolepsy is first you have to do a diagnostic test. It's called a multiple sleep latency test. It's after a sleep study is done. And then you can have an agent, an orexin agonist, which I'm forgetting the generic and the brand name to treat it. Modafinil can also be used as a medication, but you can't give that in children because of Stevens-Johnson syndrome, and that also comes with the side effects. All right, so I've talked a lot. Guys, I'm so glad you joined us. One of these, just want to check the time for a second. Can anybody comment what time it is, Eastern Standard Time? Because I can't see it on my phone, unfortunately. But we're going to do more of this kind of going throughout the week. It's basically, thank you so much. We got 5 more minutes. Okay, so I'm going to answer some questions that come up, and hopefully, now it's 6:30. Okay, all right. Well, basically, again, I'm Dr. Sood. I am an adult psychiatrist and a child and adolescent psychiatrist. I work with Dr. Sybil Wale and Dr. Niazi, who does awesome videos. You guys should follow us. We're all board-certified adult and child psychiatrists. We're all physicians. And so that's exactly kind of what we're trying to do. And every day from Monday through Friday from 6 to 6:30 after clinic, I'm going to host a TikTok live that basically goes over different meds, different topics. If you're interested in anything that you're learning and everything like that, feel free to comment, follow, type out kind of like, what you're interested in. I'm happy to kind of try to talk about these topics. We're not currently working with any brands or anything like that, so a lot of our stuff is trying to be as non-biased as possible. Kind of my disclaimer in everything is that I'm a guy on TikTok, and yes, I'm a physician, but you should be having these conversations with your doctor and your therapist if possible. Use this as a tool to teach you a little bit, but any decision you make in your medical decision making needs to be with your doctor, always. And tomorrow, I'm going to be talking about atypical antipsychotics, such as Seroquel that was brought up. We're going to talk about why we use them, why, what are the side effects of them long term, what are the different classes of them, a little bit of that history, and then we are going to field some of your questions, okay? All right, have a wonderful night. Thank you guys so much for your time. I appreciate all the follows and likes. Have a great evening.